External validation of nCLE findings in the diagnosis of pancreatic cystic lesions. This is the introductory lecture before the phase 2. The initial few slides detail the types of pancreatic cysts and the current guidelines in managing the same. All the observers are very familiar with these guidelines. We will quickly go through these guidelines to reach the discussion on nCLE findings. The outline of this talk includes discussion of epithelial patterns, new vascular patterns, review of the training set, a brief review of the study methodology, followed by the study overview, includes test 1, test 2, and eventually statistical analysis. The goal is to have abstracts for both ACG and APA meetings. The deadline for both these meetings is June 13th. The plan is to submit this to GIE or endoscopy when it's ready as a manuscript. Manuscript authorship requires completion of test 1, test 2, and review of the manuscript draft. The objectives of the study are external validation of EUS nCLE criteria for diagnostic differentiation of pancreatic cystic lesions, that is mucinous versus non-mucinous cystic lesions. The sub-objectives are validation of current epithelial and vascular patterns and validation of novel vascular patterns. The question is, why do we need to identify vascular patterns? Some IPMNs have patchy distribution of papillae, and some of these IPMNs with low-grade dysplasia have very thin papillae and may not be observed. Further, mucinous cystic neoplasms or MCNs can have a patchy distribution again and areas of denuded epithelium or areas of chronic inflammation. Thus, recognizing characteristic vascular patterns may augment diagnostic differentiation of cystic lesions, that is mucinous versus non-mucinous pancreatic cystic lesions. So far, these are the specific epithelial and vascular patterns which have been validated. IPMNs have papillae or finger-like projections. MCNs have epithelial bands which are either single or multiple. They appear like sand dunes. They have a horizon type configuration. Cystic neuroendocrine tumors have a trabecular pattern. They have nests of cells surrounded by vascularity or fibrous tissue. Pseudocysts have a dark background where the inflammatory cells have autofluorescence, and pseudocystadenomas have the classical superficial vascular network. The papillae in IPMN can be observed in various configurations. You could see it longitudinally with the vascular core. You could see the dome of the individual papilla, or you could see them as donuts or circles with bright inner core. You could see a cluster of papillary domes, or you could just see alternating dark and white bands. As long as a papillary epithelium is recognized, this could be a mucinous lesion, which could be an epithelial band or a part of a larger papilla. Here are some examples of papillae in a patient with IPMN. We see alternating dark and white bands. The dark bands are the epithelium of the papillae. The white is the inner vascular core. These papillae are seen in various configurations. As we all experienced, the image moves so fast, and we typically have to review the images after slowing it down, watching the images frame by frame. This is another patient with IPMN where you're seeing the surface of the papillae, what appears like the surface of a brain with gyri and sulci. The probe is kind of hovering on the papillae before kind of diving in and catching the papillae in their longitudinal views. Mucinous cystic neoplasms have a different appearance. They typically have very thin epithelial bands, which could be either single or appear in layers. When they appear in layers, it looks like sand dunes. Typically, we don't see a finger-like configuration. Rather, they extend horizontally across the cyst. Further, we don't see the vascular core which is seen in IPMN. In this example, in a patient with MCN, we see layering of epithelial bands. While examining patients with MCN, these epithelial bands are difficult to find, and typically we have to slow the frame rate and review the image later. As you see, this in this case, it looks like waves in the sea or sand dunes, and this is a patient with multiple layers of epithelial band. But sometimes all you might just see is one epithelial band. So once we find an epithelial band, we need to try to keep the probe steady and image the adjoining area where more bands may appear. In some patients with high-grade dysplasia, these bands can appear very thick and have variable thickness throughout. This is a patient with a pseudocyst. These lack blood vessels, and thus the background typically appears very dark. The only reason the background might appear bright is when your probe is kind of too deep through the pseudo wall of the pseudocyst. So the inflammatory cells are autofluorescent, as shown in studies involving the lungs, and thus we see bright particles against a fairly dark background. And this image is pretty much consistent in the cyst, meaning wherever you place the probe in the cyst. It's important to know that MCNs with chronic inflammation can have foci of inflammation with a dark background and fluorescent inflammatory cells. So in MCN lesion, it's important to move the probe around to catch the foci of epithelial bands. MCNs may demonstrate inflammatory contents and may get diagnosed as pseudocyst not only intraoperatively but also by histopathology in the presence of a denuded epithelium, and this has been shown in previous studies. Cystic neuroendocrine tumors have a very classic pattern with trabeculae of cells separated by either vascular or fibrous tissue. This pattern is produced only by a cystic neuroendocrine tumor and is not seen in any other type of cyst. This is an image from Bertrand's recent paper where immunostaining demonstrated significant fibrous tissue separating this trabeculae of cells. These trabeculae or nests of cells have various shapes and configurations. So the classic image pattern again is trabeculae or nests of cells. Here is the video from a patient with a cystic neuroendocrine tumor. Again, the probe moves pretty fast. The trabeculae, to identify this nest of cells, you have to hold the probe steady and try to image a specific area where you see a collection of cells separated by fibrous tissue. If you move the probe too fast, then you may not be able to pick up the pattern. The vascular patterns that are visible during EUS nCLE are: 1. A rope ladder vascular pattern, which is preferentially seen more in IPMNs than MCNs. A branching pattern, which is seen in both mucinous cysts, the IPMNs and MCNs, as well as cystic neuroendocrine tumors. The Fern pattern, which is the superficial vascular network of pseudocystadenomas, and pseudocysts lack blood vessels. The rope ladder vascular pattern is seen in mucinous cysts. Thus, the primary validation is to prove that they are seen in mucinous cysts. The pattern is essentially like a rope ladder with horizontal or diagonal rungs of the ladder which connect these parallel blood vessels. The diameter of the blood vessels is fairly constant. It's important to note that the density of blood vessels is not as intense as those in pseudocystadenomas. Here is an example of a rope ladder vascular pattern in a mucinous cyst. You will observe that these branches run kind of parallel to each other. The diameter of the blood vessels is fairly equal, and you also see the gyri and sulci appearance suggestive of IPMN. Occasionally you see diagonal or horizontal rungs of the ladder which connect the parallel running blood vessels. The thought process is that this pattern is produced because of the alternating vascular core and papillary epithelium. Thus, the suggestion that this pattern is more likely to be seen in IPMNs. MCNs rarely can have papillary structures and can generate this pattern as well. The branching pattern is primarily observed in mucinous cysts. In this pattern, the successive branches have smaller diameter than the preceding blood vessels. They are not as dense as the Fern pattern or the superficial vascular pattern of pseudocystadenomas. The vessels could run parallel, but they appear to branch off from a preceding blood vessel. Here is an example of a branching pattern in a mucinous cyst. What we see is the blood vessels initially which appear to run parallel, but as you trace them, they are coming from a main branch. The density is not as intense as the superficial vascular network or Fern pattern of pseudocystadenomas. These patterns are more frequent in MCNs than IPMNs. You can also see some reticulation or network between the branched blood vessels. The next pattern is the Fern pattern or the superficial vascular network. These are dense, tortuous blood vessels coming from a central vessel. They have a typical Fern pattern, then tend to preserve this pattern. As observed in this picture, the RBCs could be filling the blood vessels, so they appear dark sometimes. Occasionally, the RBC appear to be floating around in these blood vessels with relatively empty spaces, where the appearance is secondary to the contrast uptake. The classic pattern of the superficial vascular network or the Fern pattern is difficult to observe in most pseudocystadenomas. One has to be fairly gentle in placing the probe delicately on the wall or the septum to catch this pattern. When it's present, it's seen clearly. Sometimes you may not catch the entire pattern the way you're used to seeing it in pictures. You may sometimes see a faint, poorly visualized pattern like what we see in this video. So you have to train your eyes to catch this pattern. Sometimes the pattern is extremely clear, like in this video, where the fern pattern is clearly evident. To summarize, the rope ladder pattern and branching pattern are observed in mucinous cyst. The fern pattern is seen in serous cystadenoma. The rope ladder and branching patterns are not as dense as the fern pattern. In the rope ladder pattern, the blood vessels are parallel to each other with connecting rungs. The branching pattern is typical of like a tree branch. Panel A in this picture shows a typical pseudocyst, which we discussed before. Panel B shows layers of cuboidal cells, most likely suggestive of a squamous line cyst, which is a lymphoepithelial cyst. Panel C demonstrates an epidermoid cyst. And panel D shows flakes of keratin, which is seen in lymphoepithelial cyst with significant keratin debris. The study methods include external validation of epithelial and vascular characteristics derived from prior studies, which include papillae, epithelial bands, trabecular pattern of cystic neuroendocrine tumors, and fern pattern of vascularity of serous cystadenoma. The new vascular pattern is branch or rope ladder pattern, which is seen in mucinous cystic lesions. It should be noted that the branched type of blood vessels is also seen in cystic neuroendocrine tumors. The novel blood vessel pattern underwent an internal derivation arm. The 30 cases were blindly reviewed by 3 endosonographers familiar with nCLE. The findings were discussed with one unblinded endosonographer. There was one disagreement. This case is included in the test sample. This slide describes the process of video editing. A single user reviewed all the videos. Intracystic areas with absence of any pattern, very dark areas, or those with very rapid probe movement were removed. The video was edited to include epithelial and vascular patterns. In the second round of editing, redundant or repetitive sequences were removed, and so also the areas of focus where the probe movement was minimal were reduced in video size. These large clips were later reviewed by the derivation group, who removed additional redundancies. The video rate was slowed down by 25% of original, and at key sequences the frame rate was slowed down to 10% of original for better review. The study flow sheet is illustrated in this picture. IOA nCLE was performed in 55 patients. We have a final diagnosis in 30 patients. Phase 1 has been completed. Following a 2-week washout, the observers will complete phase 2. The purpose of the phase 2 is for intra-observer reliability. Statistical analysis will involve kappa statistics, which is a Fleece kappa for intra-observer agreement and a Cohen's kappa for intra-observer reliability. Landis and Koch interpretation of kappa values will be used for the analysis. Sensitivity, specificity, positive predictive value and negative predictive value for the detection of mucinous cystic lesions will be calculated for each observer in both phases of the intra-observer agreement study. The sample size calculation was performed prior to performing the study. This is the study data collection form. 3 columns have been removed. The column involving image quality has been removed. The first column is a patient ID followed by presence of papillae or epithelial bands, yes or no. The second column is a branched or rope ladder type of blood vessels, which is yes or no. The third column, which was actually the visualization of a rope ladder pattern, has been removed since there was confusion in filling this column. The current third column is observing a fern pattern or the superficial vascular network, which is yes or no. The next column is detection of a dark background with bright particles. Following this, you will evaluate if this is a mucinous or a non-mucinous cystic lesion. Then you will identify if any of the cysts have a trabecular pattern, which is fairly classic for cystic neuroendocrine tumors. The last column, which is kind of overreaching, is to diagnose what kind of a cyst it is based on the knowledge you have gained on nCLE image interpretation. So you will either diagnose this as IPMN or MCN or pseudocystadenoma, or this could be a pseudocyst or cystic neuroendocrine tumor. Please note that if you are unable to pick up the pattern, you can indicate the diagnosis of others. This test sample involves consecutive patients who have presented for EUS evaluation, and there are some rare types of cysts for which we don't have a specific diagnostic pattern at this time. These cysts, which is classified as others, are not frequent and are rare, but please do keep this diagnostic category in mind when when completing this last column. Here are some guidelines for diagnosing these various cyst types. IPMN tend to have papillae. Sometimes they are not complete, they are just incomplete papillae where you don't see the classic finger-like projection. They may or may not have classic vasculature, which is either a row blood vessel pattern or a branched pattern. MCNs or mucinous cystic neoplasms have epithelial bands which are either singular or multiple, which may appear as layers. They may have vasculature which is either branched pattern or rarely rope ladder pattern. Some MCNs do have evidence of chronic inflammation with denuded epithelium and thus may have dark areas with inflammatory cells. Pseudocysts, on the other hand, have a dark background all through with some inflammatory cells which have autofluorescence. So this appears like a dark background with bright shiny particles. The superficial vascular network or the fern pattern is classic for pseudocystadenomas. In some patients, this pattern is not as classic as you're used to seeing, but this involves practicing and picking up this very specific image pattern. Cystic neuroendocrine tumors, on the other hand, have a very specific or very classic trabecular pattern which is not seen in other types of cysts. Rarely they may have some branched blood vessels which can be observed. Expect to see uncommon cystic lesions with the absence of any known pattern. This reflects routine community practice at a tertiary center. As mentioned, the trabecular pattern is specific for cystic neuroendocrine tumor. Some of the patients have videos of very short duration. Again, this reflects reality because there was not much variation in nCLE pattern in certain cases. This videos at the website provided. Please remember to turn autoplay off, which is on the right upper corner. Click theater mode or full screen mode. Start with video 1 and follow sequence. Please pay attention to the video sequence when you complete the data collection form. Please do not complete the data collection form where the sequence doesn't match with the video you are watching. That is, make sure the video identification number matches with the patient identification number on the data collection form. You can decrease or increase the play rate of the video using the settings feature, using the tool set at the right bottom corner of the video. Adverse events, 3 patients, it's 3 out of 55 developed acute pancreatitis with a risk rate of 5.45%. The risk was proportional to image acquisition time. That is, longer acquisition time was associated with the complication of acute pancreatitis. It's 8 minutes versus 6.4 minutes. Further, the risk was highest in the first 25 cases, that is all 3 cases occurred within those first 25 cases. One patient, it was associated with patient movement and with trauma to the tail of the pancreas by the 19-gauge needle, even before we introduced the nCLE probe. In two other patients, both women had MCNs in body and tail, body or tail, and they had mild acute pancreatitis following EUS FNA. In conclusion, EUS nCLE can potentially improve preoperative diagnostic performance in evaluation of pancreatic cystic lesions. However, this needs validation in multi-center studies with a larger number of patients. Endosonographers should be comfortable with the technique and also image interpretation. Finally, research and development involving a 22-gauge needle compatible probe would increase the ability to explore and theoretically decrease the risk of pancreatitis. It may also encourage more endosonographers to use this technology. I want to thank our EUS team, so also our chairman, Dr. Darwin Conwell. I also want to thank our past and current pancreatobiliary surgeons. Specifically, I want to thank our GI pathologist, Dr. Benjamin Swanson. Thank you.